Hello, welcome to those who are joining. We're just waiting a few minutes for a few more people to sign in, and then we will start the webinar. Thank you to those who've joined the webinar. We're just waiting a few minutes for more people to join. So thank you for being patient, and we're looking forward to an exciting meeting. Okay, thank you to everybody. I'd like to welcome you to this very exciting webinar. We have a very full program, so we will start promptly. I just want to alert everybody, there will be translation in French, Arabic, and Spanish. So if you just click on the globe on the bottom, you can find the interpretation there. If you have any questions, please put them in the Q&A button. And if you have any problems with connections or with translation, just put that in the normal chat. So we have this very passionate subject that very many people are interested in. So we've had a huge interest in this. It is being managed by the IFE core group, webinar working group. There's been a series of webinars, and you can see from the slide that there's many partners that are involved. So we thank the supporting donors who have made this possible. The IFE core group is made up of many different international and national agencies and volunteers, individual members. There are a series of resources you can see with the QR code. So we welcome you to go to those. IFE as in infant feeding and emergencies. This meeting is really an exciting collaboration between the IFE core group, also the MAMI Global Network, which focuses on under 6 months and their mothers at risk, UNICEF with the Global Nutrition Network, and also the Disability Working Group. You can see on the slide our objectives for the meeting. We really want to share the resources that are available, especially with feeding problems, with children with feeding difficulties and disabilities. We want to sensitize the audience to some of the problems in the language. We want to raise awareness that it is possible to do things in emergencies for these affected children and caregivers. We're very excited to share a newly developed decision tool for emergency practitioners. So you'll hear about that, and that will be available for people to try and use. And we also have some experts on a panel who will try and answer some of the key questions. So with that, I will pass. We're going to start with a very brief Mentimeter to ask some questions. We will then have a brief presentation on the resources that are available, and then followed by a presentation on the new tool, followed by a panel discussion and question and answers. So we'll just move to the today's presenters. We have Dr. Marco Kerak, who will be on the panel from the London School, Jodine and Alessandro from the IFE group. and Bindiborg. Linda from the UNICEF headquarters. Maureen will be speaking, as well as Kate Miller. So we can open the Mentimeter. We just have a few questions for everybody to answer. And please enjoy the meeting, and we hope that we'll have some lively interaction at the end with the question and answers. Thank you.
Hi, Nikki. Thank you so much. It's Jodine Chase here. And to get us started, we're going to ask you a few questions about your level of experience with infant and young child feeding in emergency contexts, with infant and young child feeding and disabilities, and what facilitators and barriers you may have experienced in providing these kinds of supports in emergency contexts. So as you can see from the slide, we're using Mentimeter. Some of you may be familiar. To use Mentimeter, you can visit the link that has been posted in the chat, or the link that you can see up on your screen using any browser on your computer or on a tablet or on your smartphone. If you can't access the chat, go ahead and visit menti.com. That is menti.com, and then enter the code for today's call. The code is 33630365. You can also use the QR code on the screen. And for those using translation, please choose yes or no in English for these first questions. And then for the third question, we welcome your answer in Arabic, English, French, or Spanish. So one more time, the code is 33630365. All right, so our first question is related to emergency contexts. We know that in an emergency, there are considerable barriers to optimal infant and young child feeding. Maternal well-being is eroded due to many factors, including displacement, stress, exhaustion, gender-based violence, just to name a few. There is a lack of privacy and support for breastfeeding. So can you tell us, please, and I see folks are already answering, if you have experience in supporting infant and young child feeding in emergency contexts? So we see that right now it's about a 2-to-1 mix here. Over 50 of our folks that are in the call today have no experience in supporting infant and young child feeding in emergency contexts, but we do have a good number, over 30 that have answered the Menti, who do have experience in emergency settings, supporting infant and young child feeding in emergencies. So for both of you, I think you will find that the webinar is going to provide useful context. I think we are starting to see the results slow down. So let's give everybody another minute or so to answer. It's now about half and twice as many folks have experience in infant and young child feeding in emergencies. And some of you have less experience. So when you're ready, please move to the next slide and we will present the second question. The second question is to get a sense from you if you have experience in supporting infant and young child feeding for those with disabilities. So not just specific to emergencies, but also in your general context. What is your experience level in supporting infant and young child feeding in those who have disabilities? And I see that the numbers here are a little more even, but it looks like we have more folks who are responding who are saying they don't have experience with supporting infants and young children with disabilities. So this session today is going to be really helpful for those of you who have no experience. And for those who are answering yes, we're interested in hearing from you about your experience too, so that we can learn from you. So we'll just wait for people to catch up to this next question, but it looks like we have a good number of answers in. Just one more time, if you're having trouble accessing Menti, you just go to menti.com and then enter the code, which for today is 33630365. And we're still getting a couple of answers coming in on this next question. So we'll give you just another few seconds, but I am anxious to move on to the third question because really this is where we want to get a sense from you about barriers and facilitators to supporting infant and young child feeding in emergencies with disabilities in emergency contexts. So please go ahead and move now to the third slide. Thank you so much for those of you who are participating in the Menti. We just really appreciate it. It really gives us a sense, but also it's important for us to be able to hear from you and hear your perspectives. So the third question now is a text box. So please answer, do you think that you can support infant and young child feeding with disabilities that are presenting in emergency contexts? And if yes, please let us know what helps you to provide this support in your context. And if no, please let us know what the barriers are to providing this support. You may have both yes and no answers, and it's okay to answer more than one. So just give us a short answer, yes, because, or no, because. And thank you so much for your responses already so far. What I'm seeing on the screen here, and I'll just read a few of them out loud. I'm seeing people are saying that, yes, there's a need for clear guidelines. I'm also seeing some barriers that are being identified is that it's hard due to lack of funding that is needed for those with increased needs. I'm hearing people say that, yes, they are supported because they have an interdisciplinary team. And feel free also to put your answers in Arabic or Spanish or French. And some of our IFE core group members will help us in reading those back so they can be translated for everyone who's listening in the call on translation. Oh, yes, there's a really good point here about that having the identified space to support families is very important. I see someone here has indicated they're not fully prepared yet, they need capacity building. I'm seeing it identified that training is when there is training, then yes, support is possible, and that positive government policies and human resources are facilitators. A barrier identified is a lack of access, a lack of material. Let's see, I see an answer here in French. Linda, if you could please voice the French answer, and then after you, there's one in Spanish, Peggy. Go ahead, Linda.
Thanks, Jody. I don't seem to see it on the screen.
I think we may have scrolled past. Oh, there, it's being highlighted now. Can you see it?
Oh, yes. So it says because the strategy is integrated in the policy, in the national policies.
Excellent. Having integrated strategy and national policy is indeed a powerful facilitator. Peggy, can you see the Spanish one?
Yes. So personal sensitivities, need to integrate and not forget the understanding and the restrictions of the counterindications for dealing with disabilities.
Yes, thank you very much, Peggy. We're seeing a fair bit of information or of identification of both as a facilitator and a barrier, the importance of adequate training. We're seeing here, and I'll read this out loud, access to adequate training for caregivers, inclusion of disability-specific strategies in infant and young child feeding programs, and availability of resources tailored for children with disabilities. I think that we're starting to see a clear direction here pointing in what people are asking for. Here's another one saying that clear guidance and hands-on training is needed. And of course, support is necessary with people who have knowledge and experience from previous projects. So I think what we're going to do now is, oh, there's a few more that have popped up. I'll give this one more minute. But thank you so much, everyone, for indicating your barriers and facilitators here. I know that in Spanish, we heard that in that country there is clear policy and guidance incorporated into national guidance. And then I'm hearing folks say that things like they need to know and they need to have clear guidelines. So I think that we will wrap this up, and thank you again for your participation in our Menti exercise. I'm now going to turn things over to Linda at UNICEF to carry on with the presentation.
Thanks so much, Jadine. Thank you, everyone. I'll wait a second for the slides to come up. Thanks so much for the opportunity to be here in this really exciting webinar. It's so nice to read the contributions. My name is Linda, and I'm a nutrition specialist with UNICEF headquarters here in New York. I'm part of the Early Childhood Nutrition unit, and I'm here to give a small introduction to the topic that we're talking about, nutrition, infant and young child feeding, for children with feeding difficulties and disabilities. And I do have some good news in response to some of those contributions that resources do exist. And so hopefully we will be able to share some of those. So I will be going through this presentation to share some resources before handing to Maureen, who will go through an exciting new resource. So first, allow me to provide a quick reminder of two important terminologies. One is what we mean by a person with disability. And as you can see, this refers to those with long-term physical, mental, intellectual, or sensory impairments, which in interaction with various barriers may hinder their full and effective participation in society on an equal basis with others. And then when we talk about inclusion, disability inclusion, this is the process that ensures that all persons with disabilities enjoy their full and fundamental rights and freedoms to fully and effectively participate with and within their families, communities, and societies without barriers and on an equal basis as those without disabilities. I encourage you to find more definitions on the Feeding Disability Resource Bank, which we will share the link in a moment. So why are we here? Because as you have all indicated, we have identified the issue that exclusion is a problem, and therefore inclusion, especially of children, in all aspects must be a priority for all of us. And so globally, we show that 1 in every 10 children have a disability. And those children with disabilities are, of course, more vulnerable. And they are more likely to suffer from different conditions, but in specifics, all forms of malnutrition, including when we talk about wasting and stunting, as you can see on this slide. Next, please. So these figures and findings reinforce the existence of this link between malnutrition and childhood disability, and also childhood disability and malnutrition. And so you can see here that cycle that we need to break. Especially, of course, as you all indicated, next please, in situations of emergencies. And as Jodine also started to introduce this topic, we know that the proportion of children with disabilities is higher in emergencies, and they're much more marginalized and excluded. Thus, the importance of ensuring that life-saving interventions, infant and young child feeding in emergencies, are especially inclusive, and we therefore speak about disability inclusive IYCF-E, or infant and young child feeding in emergencies. Next, please. So what are we doing? I'd like to introduce the Disability Inclusion Working Group, which is part of the Global Nutrition Cluster. This is a group that has been working to ensure disability inclusive nutrition response in emergencies and has been prioritizing this latest task that we are going to hear about today, that aims at ensuring that frontline practitioners in emergencies are equipped to improve the nutritional outcomes of infants and young children with disabilities and feeding difficulties. Next, please. So the Disability Working Group has been engaged in ensuring that resources are available for emergency responders. And so I'm sharing here the group page and encouraging you, of course, to check some essential resources. You can see here ones on the screen. I've pasted 3 screenshots about responding to emergencies in specifically for disability inclusive response in nutrition. Next, please. And then a very practical resource that I wanted to highlight is the essential actions on disability inclusive nutrition that you can see here. And again, encouraging you to visit the page and check this resource, a very practical checklist. And then next, please, 3 more that are more programmatic in terms of programming, planning, and these are the tips for the nutrition cluster and essential actions for cluster coordination, all of which you can find on the working group page. Next, please. But I do wanted to spend a few minutes to highlight an important resource bank that houses resources to address both disability inclusion and feeding difficulties in general, including in emergencies. And so this Feeding and Disability Resource Bank was originally developed by USAID Advancing Nutrition. This is USAID's flagship multi-sectoral nutrition project, and it started in 2018 all the way until the end of last year. This was led by JSI. And then since early this year, UNICEF has transferred the bank to its platform and has been managing it. And so you can see here the link, and I encourage you to take a look at this resource bank, as it is a repository of essential resources around addressing feeding difficulties and disability inclusion in nutrition programs. Next, please. And so,
Linda, have we lost Linda?
I'm here. Can you hear me?
We can hear you,
Yes.
Linda.
Yes.
Okay, great. So the resources in the resource bank, just maybe a bit of detail here. These are grouped into 5 sections. You can see on the screen, including looking at identifying feeding difficulties, managing feeding difficulties. The page also has additional features where you can search by different technical areas, and you can also find original images when you visit the IYCF image bank, which you can also check as we share the link. In fact, I encourage you to navigate the IYCF image bank, which is another database of images that you can use for the development of disability inclusive resources. Now, within this resource bank, I wanted to just highlight a few of these resources that are on the bank. One is the Health Practice Guide, which provides guidance on ensuring children with disabilities have access to inclusive nutrition and health services, and the Nurturing Care Practice Guide, which also provides practical approaches with a focus on nurturing care. And then an existing recent resource, next please, which was launched earlier this year, is the Community Infant and Young Child Feeding Package, which was updated to ensure the inclusion of care of children with feeding difficulties. Again, encouraging you to access this link as a community resource. And then another very recent resource is the Save the Children Disability Inclusive IYCF package, which provides guidance on IYCF disability inclusive programming. And there are much more. This is just a very small list of a few resources that the Disability Working Group found that exist, yet we are still finding challenges in terms of addressing the need. And therefore came that need to develop a tool that combines essential resources and provide a practical sort of roadmap to address the needs of infants and young children with disabilities and feeding difficulties. And given this heightened vulnerability in emergencies, the work for the development of this tool that Maureen will be speaking about emerged. And so with that, and next please, and the hope that sharing these resources and the work that the groups are doing would prevent exclusion, ensure inclusion, I'm going to hand over to Maureen. Thank you.
Thank you, Linda. That was so wonderful. My name is Maureen Daikinga, and as a doctor of public health, a speech-language pathologist, and a consultant, I have spent more than 24 years promoting the inclusion of infants and children with special healthcare needs. So I am delighted to present the work that we did with UNICEF with you today. Next slide. Okay, so the purpose of this project really overall was to prevent wasting and other forms of malnutrition, respond to nutritional needs, and mitigate poor nutrition by ensuring that nutrition in emergencies practices support all children, including infants and children with disabilities. And so the part that I really focused on for this was the response, the prevention, and the mitigation components in emergency settings. Next slide, please. The key deliverables for this project started with an inception plan that was developed, a strengths-based needs assessment that really focused on what's working, what's currently being used in terms of tools, in terms of technical capacity, in terms of policies, in terms of practices. And then a decision tool would be developed from that. We actually developed 2 decision tools. We developed an online and an offline twin. We created an e-learning module that's a very brief course that teaches how to use the tools, and it's very practical and hands-on and short. We performed a gap analysis and provided recommendations on areas where there are still gaps that we could be filling in with inclusive practices or tools. And we created a summary report where we put together all that information. Next slide, please. So one of the big questions was, how is this tool specific for emergency contexts? So the first thing, it was inspired by frontline workers working in emergency and humanitarian settings. They asked for this. You asked for this in many cases. It provides an entry point from those various emergency contexts, those phases, whether it be response, mitigation, or prevention. It is intended to be standalone, meaning that it doesn't require additional training and it doesn't require participation in a specific program, but it's not standalone in that it doesn't have to take the place of anything that already exists. It required us to use only open source content. So any resources that were built into a program that you would have to participate in or that were not open source couldn't be included. It didn't require any sort of course completion or attendance. That's not what it's intended to do. And it's not associated with, as I said, additional programming. It also builds upon the assess, analyze, act model, which is currently used in emergency contexts. And we'll talk a little bit more about how we built upon that. So it's important to know what this tool does do, which is it provides a hands-on tangible resource. It does not take the place of a professional working with a health or a feeding professional. Okay, so I wanted to talk a little bit about how it was developed. We performed a very robust desk review. That's where we looked at all of the technical resources, the policies, the programs, the practices. And then we also conducted key informant interviews. So these were conducted throughout the project. The key informants were folks who represented implementing programs, overseeing programs, and those who have developed resources themselves. That information, along with the desk review, allowed us to perform a technical analysis, which was where we basically looked at all of the resources. We winnowed them down to 44 of them, which were reviewed and cataloged. And basically they were cataloged by what information we could take from them that would contribute to the tool. And then we did the same with the key informant interviews. We did a qualitative analysis, and this is where we took all of the salient content, the most important information that was shared. That could be language to use, that could be processes, that could be facilitators, that could be barriers. And we took all of that content and we categorized it. And all of those things allowed us to iteratively and collaboratively develop this tool. So there were many versions of the tool. It continued to develop, and as there was more contribution from more people, all of that information was incorporated into the development of the tool. Next slide, please. This was a one-pager that we added to the project. You can use this one-pager to let folks know what the tool is, who should use it, what it's intended to do, where it can be found. And this one pager is also located at the beginning of the on or the offline version, which we'll talk more about in a minute. So you can start to understand a little bit about who should use this tool and who shouldn't use this tool. It's structured, next slide, please. It's structured we start with, we select the infant and child age category. So we broke up the age categories into 4 primary categories that just capture some of the most important developmental feeding skills. And then once you enter that information, you can use resources to assess the oral structures as you're assessing nutrition. Then you go into analyze and act. So these resources will help you analyze the feeding difficulties that you're observing and act by using a functional action plan. The functional action plans are based on functional feeding difficulties that are described rather than associated with disability. As we know, disabilities have a very, very complex and range of abilities and limitations, and we didn't want to define the feeding difficulties by disability. We wanted to define the feeding difficulties by the challenges with nutrition and feeding. The appraise section was added on to this model, which is where we use the resources to appraise the response to these feeding strategies and see if it's working, see if we need a different plan or different resources. And then assign is where we really integrate these children, which we know, children who are in emergency contexts, we know infants, and we know children with healthcare, special healthcare needs and disabilities. We know that they are at very high risk to need other supports. And so we really wanted to show how they could be integrated into other programs. Next slide, please. All right, please play the video. And this is a demonstration of the offline version. And I don't think we're hearing the volume. You may have to.
Sorry, you're not hearing the volume?
I'm not.
Okay. Let me try again. One sec.
select 6 to 11. Once you've downloaded the PDF, you want to find the table of contents. At this point, you can click on Start to select the age range of the child. For the purposes of this demonstration, we're going to select 6 to 11 completed months. This is the assess phase. So during your assessment of health and nutrition status, you're going to always refer to your local protocols and use the existing tools. This decision tool is meant to supplement what is already in use. It's not meant to take the place of something else. So we're going to follow the local protocols and then answer the question, what is the status of the infant? Depending on the answer, you'll make the decision about what to do next. So if your option is complicated, severe, acute malnutrition and wasting, stop. Do not use this tool. Instead, follow national nutrition protocols and refer to the nearest hospital. If the infant has uncomplicated, severe, acute malnutrition or moderate acute malnutrition wasting, use this tool. If there's no acute malnutrition or wasting, do not use this tool. Instead, just follow local nutrition protocols. So for this demonstration, we're going to say that we've selected this category, and we're going to click on the link for Assess Oral Structures. That takes us to instructions of how we can assess the oral structures for this age range. Step 1, we'll observe the infant during feeding or at rest. Look for weakness in the tongue, lips, or jaw muscles. Step 2, we'll observe the structure of the lips. What we're really looking for is any sort of hole or cleft. And then step 3, use a light to look inside of the mouth. Look for holes or clefts on the top or the roof of the mouth inside. Then you have some decisions to make. If there is no cleft, you can go to Analyze Functional Feeding Concerns and act. If there is a cleft, you can go directly to the action plan that's intended for children who have cleft lip or palate. Liquid comes out of nose. For this demonstration, we're going to go to the next step, which is Analyze Functional Feeding Concerns and act. Click on that link and it jumps to that section for this age range. So the next step is to ask the caregiver, what feeding concerns do you have? Depending on what the caregiver shares, you'll find the functional feeding description that matches the most closely. So for this demonstration, we're going to select not gaining weight. And then we're going to follow this feeding action plan to address not gaining weight. Number 1, we're going to follow breastfeeding strategies, and that includes trying different positions. Number 2, we're going to use strategies that encourage attachment, and that might be skin to skin, lip stimulation, or drip drop. And remember, we just have very simple descriptions and very simple pictures. The purpose of this tool isn't to require a lot more education. It's just to give some simple tips and tricks to help these really needy little ones who are being served in emergency contexts. Then step 3, for this age range, we want to make sure we've introduced complementary foods. And we're going to follow the UNICEF and WHO guidance, and that's provided right here for this age group. And then step 4, we're going to follow the strategies for safe feeding by matching the texture of the food to the skills of the child. And we're going to introduce the spoon. Here's a list of different skills that you might observe that are needed to match with this texture, a smooth texture. Here's the next progression of skills to observe to show that you're ready to progress to this texture. And then here's a list of skills that you can observe during this age range that allow you to progress to this type of texture food. Now, each of the foods should be available and relevant to the culture and context where you're working. But as closely as possible, you want their consistency to match. Baby Ubuntu Resources has given us a nice description of how to place the spoon, what to expect, what to see the child do, and the positioning. And then here's just some great reminders about we want to make sure the caregiver and the child practice good hand hygiene. We want to continue to breastfeed, and we want to support the infant on the lap while they're receiving spoon foods or solid foods, or in a specialized seating. And now we're ready to go to the next section. So this section allows us to appraise the response to feeding strategies. And what that means is we're just going to take stock and we're going to figure out if what we've tried has helped or not. So it's going to start with a question: did the feeding improve? Now this question might be asked maybe at the next growth monitoring or nutrition monitoring visit. It might be asked during counseling sessions. If you've had a chance to try some of the feeding sessions right now, in the moment, you can ask the question here: did feeding improve? And then if the answer is yes, you're going to continue to follow that action plan and move on to the next step. If the answer is no, you're going to have to refer back to those local protocols, especially if they have severe acute malnutrition and it's complicated. If the child falls into that medium category again, you may want to look back and decide, are we going to try this action plan for not gaining weight again? Or do we need to look at the action plan for coughing and choking? And so you can explore that if they belong to this category here. For this demonstration, we are going to say the child has improved, and we're going to move on to assign next steps. This section is really just intended to be a reminder for all of us of what a high priority malnourished children and children with feeding difficulties and children with disabilities are. And so there are some resources here that show us where we can get products or specific technologies that could be helpful. Maybe it's supportive seating, maybe it's modified cup, maybe it's something that helps with eating solids. And then most importantly, we really want to encourage coordinating with country officers to link these humanitarian efforts and move more towards development and away from just responsiveness. So really build on the resources that exist. And these resources are listed here. Engage with the community, take advantage of cash transfers if they're there, if there's food security measures, early childhood development, WASH, and psychosocial supports. And those supports are not just for the infants and children, but really for the caregivers as well. Thank you so much. Now I'm going to just briefly go through our very first iteration of the online module. It's not quite ready to be shared broadly, but when it is ready, it will be on the web page with the offline version. And so I'll just show you, if you're able to use the online version, how quickly you can move through it. Okay, so we're going to start here, select the age range of the child. And for this one, I'll pick 12 to 23 completed months. I'm going to look at the status of the nutrition, and I'm going to see here uncomplicated severe malnutrition and wasting. And then that takes me to assess oral structures. So I get that same information about how to assess the oral structures. And then here, if I have a cleft or no cleft, I'll make that selection. So for this one, I'll say no cleft. And then I'll go to what feeding concerns do you have? And so if I want to say not gaining weight, I can just select that right here. And then I can appraise the response to feeding strategies, just as I did before. And when I'm done, I can go to the bottom. Yep, and when I'm done, then I'm all set. So I can look at appraised feeding. Did it improve or no? They still have complicated, severe, acute malnutrition. For this example, if I say yes, feeding is improving, then that takes me to go to assign next steps. And then I receive the same information here that I received in the offline version. So it's a lot quicker if you're able to access the online version, but both of the tools have the exact same information provided. The online version just navigates the user through a little bit more quickly. Okay, so in summary, the tools have 4 age categories. There's an online and an offline twin. They address a range of functional feeding difficulties, and I really wanted to demonstrate the focus of the tool, but those feeding difficulties touch on things like if you have cleft lip and palate, what does that look like? The way that you get to that information is through the functional feeding difficulty that we typically see, which is that liquid comes out of nose. We also, for different age ranges, touch on chewing difficulties, and that's indicated by food spilling out of mouth and concerns with aspiration or food or liquid going into the lungs. And so we address all of the things that we can address with this tool, with the purpose of this tool in emergency contexts, understanding it doesn't take the place of what we're hoping to achieve if we reach out to a feeding specialist or a healthcare provider. And remember, there are multiple steps that may take place over time. So that's the assess, analyze, and act, appraise, and then assign. And now it's my pleasure to turn this over to Brooke for questions.
Thanks, Maureen. We have a few questions that have come through the Q&A. If for now, is the tool available in other languages? And Maureen, are you?
Yeah, the tool currently is available in English. Linda might be able to share a little bit more about the plan for it to be available in different languages based on how the website works. Linda, are you able to speak to that?
Yeah, I can come in, and this is of course a conversation that applies to a lot of the tools that are developed, where you would have a generic tool, and then depending on the context and the usage of these tools, these would be translated. And so normally it would be regional adaptation, translation, depending on the context. As the Disability Working Group, I think there are conversations about supporting this as we move forward. Thanks.
Great, thank you. And is there a paper-based version, or is there any paper-based disability tool? Linda, maybe you.
So the offline version is set up as a searchable PDF. So if you download it to your computer, you can touch on the hyperlinks and it jumps you through. If you would like a paper version, it will require you to print out the actual tool itself.
Yeah, if I can just also come in here, that in some tools also you have some instructions for the countries and the teams on sort of the specifications of when you want to print out those tools. I mentioned the community IYCF counseling package, for example.
Thanks, Linda. Thank you very much. So a question specific to this tool, Maureen. As I understand, this tool is for children with acute malnutrition. How about those who may have feeding difficulty without acute malnutrition or wasting? appreciating that it was mentioned to use local guidelines, but it's in their experience that they don't often exist.
Oh, that's a great point. Yeah, this is a great foundation for us to build off of. And in a perfect world, these strategies would be preventative. They wouldn't just be in response to difficulties. And I think as the tool becomes more broadly used and people are familiar with it, they may find that it's okay to use the tool and use some of the feeding action plans for children who are not yet malnourished or don't fall into that category yet. Maybe even for children who are just underweight. That was actually one of the gaps that we noted in the current protocols, is that there aren't a lot of services and resources available for underweight children until they fall into that more severe category. And so it's definitely a gap that I think we could address. It wasn't the purpose of this tool, but I think it could be helpful in the future to use some of these resources more broadly.
Great, thanks very much. So we'll go to the panelist discussion. Thanks, Maureen and Linda. I'm sure there'll be more for both of you to jump in. And we'll have some questions that came in before when you were all registering, as well as some that have come in through the webinar. So I'd like to introduce Marco and Kate, and both of you, please, if you can, introduce yourselves for the discussion, and then we'll go into the questions. Thank you.
Hi, everybody. So I'm Marco Carrack from the London School of Hygiene and Tropical Medicine. So I'm a paediatrician by background and currently working on severe malnutrition, disability overlaps, and with a particular focus on infants under 6 months. So yeah, delighted to see that group among the many represented in the tool. Thank you.
Hello, everyone. I'm Kate Miller. I'm the Feeding and Disability Specialist at Spoon, and Spoon is dedicated to improving feeding and nutrition for children with disabilities and children without permanent family care. I'm so glad to be here. Thank you.
Great, thank you very much. So we'll start with some of the questions that came in through the registration. Ray, would you like to go through some of those?
Hiya, thanks, Brooke. Yes, so one of the questions we have is, what are some of the recommendations for cleft lip palate, and where can we find tools for this?
I think you'll see in the tool there is some guidance provided directly to address some of the specific feeding challenges for infants and children with cleft lip and cleft palate. There are also some great feeding and nutrition resources available within the bank that was shared earlier. So those would be a really, really great places to get started.
Thanks, Kate. We have another question here. How can we increase awareness in families and caregivers regarding the signs and symptoms of feeding difficulties?
So I think that's Kate. Do you want to take that one first? Then I can come in.
Sure, great. I think part of that is increasing our awareness as service providers of the signs and symptoms of feeding difficulties, recognizing those feeding difficulties early, and then providing strong counseling to caregivers so that as they feed their children multiple times a day, that they can recognize when their child is struggling, and they can begin to address those challenges.
Yeah. I mean, I'd also say that families generally know that there's something not quite right. They know that their child is different to others, to other siblings, to neighbours and others in the community. So I think people always know that there's something up, but it's about having the healthcare workers. And I think that's where this tool and the many others are really, really key. That sadly, they also know that if they go to healthcare workers, not much will happen. And I think that's where this tool actually fills a really key gap and a key area in that, by also heightening the awareness and getting some actual actions that healthcare workers will do, it'll transform that dynamic. So rather than to sit at home and know that there's something right, there's something wrong, but not know what it is, or not want to go because they're sure that nothing will be done, there will now be an incentive to go because they know there'll be action, there'll be responses, there'll actually be things that people can do.
Thanks both. We actually have a few specific questions for you both as well. So I'll start with a question for Marco. What is the status of disability in the new 2023 WHO wasting guidelines?
No, thanks, Ray, and thanks to that questioner. So I think that's a really important point. And I think what's great about the new WHO wasting guidelines, and I think many of the national policies, that they are mentioning disability now. So disability is highlighted. But I think one of the things that also came up is that there's a big need for practical tools, practical resources, because it's one thing having disability on the agenda, which is necessary, but it's not sufficient. And we need practical tools like the one just presented to actually operationalize that, to make things happen, to get actions in frontline clinical services. So it's there politically, it's there in policy, but the key thing is to make it happen in practice. And so I really encourage those on the seminars who share this tool, share others that are out there, compiled by Nikki and ENN and others, as well as by the UNICEF cluster, to actually make it happen on the front line.
Thanks so much for sharing that information, Marco. Really great to hear more on the inclusion of disability in the WHO guidelines. Kate, if I can come to you for our next question, how can we support infants with feeding difficulties and disabilities when we work in a context where there are no tools or equipment?
Thanks, Ray. You know, a lot can be done by frontline workers, but that doesn't exclude the need to continue to invest in skills and referral services. But to keep it practical, I would say first would be prioritizing safety. So safe and efficient feeding should have minimal risk for aspiration. So when the food or liquid goes into the airway instead of the stomach, it should provide sufficient nutrition for healthy growth and development, and it should be pleasurable. So safety means preventing or reducing the risk of infants or children choking or aspirating. Part of that is, as we discussed, is recognizing the signs of feeding difficulties and the signs and symptoms of aspiration. So this could be as simple as coughing and choking, or a wet sounding voice, watery eyes when their face changes color, change in breathing, congestion, runny nose, those sorts of things. And then encouraging caregivers to position infants and children as upright as possible. So, you know, individualized care is critical. So each child may need something slightly different, but in general, as upright as possible is a safe position for infants and children. So you could use towels or cushions or blankets rolled up to help get a child into a more optimal position, and that sort of prioritizes safety for them. Secondly, I'd say we want to promote responsive feeding, and this is an area that you all are very skilled at. I think that includes watching for and responding to hunger and fullness cues, especially for children with disabilities who may not have the communication skills you'd expect at the age that they are. It means respecting the infant or child's communication, encouraging an appropriate pace. So offering bites of food when the child indicates hunger, when they indicate they're ready for the next bite, and when feeding a child sitting at eye level with that child. And then third, I would say encouraging do no harm. So making sure that caregivers are not forcing the child to eat, and helping them understand the dangers of force feeding, making changes slowly. So watching the child to communicate what they can tolerate, and observe for how they accept the strategies you're trying, making sure that whatever you're doing to try to improve their feeding, that you are watching the child for what works for that individual child, and helping caregivers know that it's okay to stop feeding the child when they indicate they're done, or to stop a strategy that doesn't appear to be working for them. I recognize there's a need for more access to the products, to the tools and the equipment that are feasible in low resource and emergency contexts. But there's still an opportunity for you as a provider to think creatively about how to meet the individual needs of the children. So you can modify common utensils, use, like I said, blankets or cushions to help support positioning. And so try to think creatively about what you have access to support the individual need of the child. And I think as an example of thinking about what skills you bring to the table, I want to tell you just briefly about some work we did with Save the Children in Somaliland. So earlier this year, we designed a disability inclusive training on nutrition and feeding to support infants under 6 months and their mothers. And one of our primary objectives was really to help the frontline workers apply their existing skill set to a population that they were less familiar with. So they had received a lot of training, for example, on positioning for breastfeeding. And so the training we were able to add to that was to help them problem solve. How do I apply this skill set I have to children with disabilities? So understanding sort of some of the specific challenges and making sure that the work they were doing included a population that they maybe were less comfortable addressing, or maybe less familiar with, but that are very much a part of every population we serve. I'll stop there and hand it back to you, Ray.
Thanks for sharing your experiences, Kate. I'm sure our audience and those working in emergencies will have found that really informative and useful. We have another question for you, Marco. What outcomes are relevant to measure when assessing the success of disability-focused research and programming?
Yeah, thanks very much. Great question. To keep it very short, just in light of time, I think the big thing is our normal metric of success in nutrition is weight gain, and that's problematic anyway. But I think here we particularly need to focus on quality of life and how trying to improve things, both importantly for the child, but also for the carer. So that can be done informally in programs through surveys, exit questionnaires, etc. Just discussion with caregivers as they exit the program, but also I think lots of tools that exist in research for those who are seeking to more formally evaluate. So there's WHO quality of life, short questionnaires, many other similar things, the maternal support, maternal perception of social support, so many questionnaires. But I think the big message is focus on quality of life. This is not just about growth. Sadly, we can't always improve that as much as we'd like. Sadly, we won't be able to prevent premature mortality, which is a big issue for some disabilities. But what we can really do, and perhaps a kind of ending thing, is we can improve things for the child, for the mother, for the wider community, in terms of how they experience it, helping them navigate and providing that supportive, nurturing environment.
Thank you, Marco. Just coming back to you, Kate, how do you suggest we approach screening for and responding to feeding difficulties?
Thanks, Ray. At Spoon, we really take an approach that combines training, tools, and advocacy. I think having tools is really, really important, but making sure they're paired with access to building that capacity and those skills to address a variety of challenges. Our work has also shown that several different types of entry points can work well. So, for example, in Lesotho, we target nutrition and feeding in preschools as well as health facilities. In Zambia, we've done it in community programming. In Uganda, it's a mix of schools and community centers and childcare institutions. On an individual level, screening is intended to identify risk and should be completed at regular intervals. It's always a first step in the process and should lead to more in-depth assessment to understand a child's individual needs. Routine screening that is integrated into regular care at regular intervals can detect challenges early. So if we can identify feeding difficulties early, then we can address them before they progress to something bigger or to have a larger impact. It's important to approach screening and responding to feeding difficulties systematically. That's what I love about the tool that Maureen just shared, is it's very systematic in the approach. Because feeding is a bit nuanced. I know we all do it several times a day, but it's a complex process. And so if we are systematic about the way we look at the challenge, that will help identify sort of where to make changes. I think in infants and children, what makes feeding challenging is that it's a co-occupation. So that means that it's something that is done together. It involves both the feeder, the caregiver, and the child. And so success relies on the skills of both the mother or father or grandmother and the infant or child. So when we're planning for programs and interventions, it's just important to keep in mind how common feeding difficulties are. So any program that targets infant feeding and child feeding, it should have a plan in place for how to support infants with feeding difficulties and children with feeding difficulties. It's a given that children with disabilities and children with feeding difficulties will be a part of your programs. And that will help you be prepared to address their needs as opposed to being reactive when the issues show up.
Great. Thank you so much, Kate, for sharing that information. I think we have time for one more question each. So, Marco, what would you say are the priority research questions to improve outcomes for children with underlying issues?
Thanks very much. I think that's a great question. I think it's both research questions, but I think research methods. So one thing that I learned from the WHO guideline group is that what's really needed are intervention studies. So I think we have lots of good experiences, lots of good programs, but I think it's really important to have some intervention data to test what actually works, how it works. And that will help us find, number one, it'll help us really understand, help us develop, and help us fine-tune things, because not everything that works well on paper and in theory is as effective in practice. And there may be tiny little things that we can change that actually make a transformative difference. But unless we examine it formally in comparative trials, we won't know that. And I think the other thing is that policymakers really need that slightly harder evidence sometimes to justify resources, spending, and investment in this really important subject. So we need to give them that harder data through intervention trials and complement it, I think, with making the economic, but also I think really, really importantly, the social, the feasibility, acceptability, and the needs case for disability. So really complement it by highlighting that this is a subject which is in demand, it's needed by both families and communities and by healthcare workers, and then it is feasible, it's acceptable, it does work. So gear things up for the GRADE process. If you haven't heard of GRADE, look it up, but it really helps things work through from theory into policy and into frontline practice, which is what we really need.
Amazing. Thank you for highlighting those key areas. And a final question for you, Kate. What can nutrition programs do to be more inclusive of children with disabilities?
Thank you, Ray. I think that programs need to include children with disabilities in any program design and plan. Like I said, taking it that it is a given, that some children will have disabilities or feeding difficulties rather than being reactive. I think it's important to remember sort of that twin track approach. that it's important that mainstream services address the needs of children with disabilities, but that also that we're strengthening systems to have those targeted indicated services that address specific needs. There's a lot that can be built on. So, you know, existing breastfeeding support, if we strengthen that to ensure that those frontline workers are equipped to also address the breastfeeding needs of infants with conditions. I think there's a lot that can still be done, but I think accessing those resources creatively currently will help frontline workers address needs while still seeking opportunities, funding policies that make our services more inclusive. So ensuring that our program design is inclusive, investing in mainstream inclusion, support for caregivers and frontline workers, and reflecting that priority in sort of international guidance, data, accountability frameworks, and aligning with the disability rights movement.
Great, thank you, Kate. And thank you both for your thoughtful answers and for sharing your experiences and expertise on this panel discussion today. I will pass back to Brooke as we now enter into the next part of our Q&A, which will be an open Q&A. Thank you.
Thanks, Ray. So I have a question. I'm going to summarize a couple questions that are kind of on wider disability. So for other disabilities outside of cleft lip, cleft palate, we have a specific question about NOMA disease, about diabetes, for example. Are there resources that address kind of wider disability as well?
I mean, maybe I'll kick off with the NOMA disease, but I think it's a good example of something that really benefits from very early intervention. So just reading an article about it recently, and unfortunately for advanced NOMA, the outcomes are poor, and it's a very, very difficult, if not impossible, to fully treat. You know, we don't fully understand what causes it in terms of bacteria, etc. So, but what makes a transformative change is identifying at those very, very early stages. So again, it's about healthcare workers being aware, because families 100% will spot there's something not right, but they need to be backed up when they actually present and when they ask the question. So it's about early referral, and again, being aware of what are the local organizations who can help, who can support. There are specialist organizations available worldwide, but it's the kind of thing we need to be having conversations between health, nutrition programs and the much wider supportive situation long before the patients actually arrive. So, you know, one thing that we did a long time back in Malawi is put together a directory of disability-related services, which might have things like NOMA, have things for supporting children with specific forms of disability in the community, and help bridge those referral links so they can be sent, they can be shared, and that the follow-up can be done. So yeah, in summary, build bridges, get to know who are the other services around and who might be able to help with a whole variety of different things, and do that well in advance of patients coming in.
Great, thanks, Marco. Another question. In a context of security crisis, we do surveys to identify food culture and vulnerability in order to meet their food needs. Once we've identified the types of food that the affected community consumes, that's our first step. So the question is, if the food that the community consumes is scarce in the first place, what can we do to anticipate nutritional needs adapted for disability in that context? So I think it's kind of more thinking ahead and planning. How can we identify in that first assessment phase? And who would like to take that one?
I mean, I could perhaps just mention first off, if Kate comes in the second part of that question, but what would be really key is actually to have disability asked about in the survey, because I think very often it's neglected. And the reality is, if we don't look for something, there's very, very little chance we won't see it, even if it's all around. And so encourage people to use the questionnaires that are available. There's a World Bank, 10 questions, short assessment tools for screening for disability. There are developmental tools, so that's related to disability, albeit slightly different, but have disability in the questionnaire, even if it's just looking for the major forms of disability, the cerebral palsies, hydrocephalus, etc., cleft lip, cleft palate, because as soon as we get a sense of numbers, that really transforms things into having the conversation. How do we provide care? How do we provide support? How do we make things better for affected individuals and their families?
Thank you. I have some practical programmatic kind of questions. One is asking about funding. Is there a recommended kind of earmarked funding, or is there some guidance with regards to budget planning or program planning with regards to funding that might be useful if someone's integrating this better into their programs?
So I think I started typing a few questions, but Kate, go ahead first.
I would just say, I think it's pretty dependent upon your program and where it's located. And so I think there are opportunities to bring in support to existing programs, right, to make them more inclusive. And then there's opportunities to build targeted support, so to develop the services that meet the specific needs of children with disabilities. So I think it depends on sort of the status of the program and where you're starting. So are you adding some information around disability and feeding difficulties and strengthening the existing program, or are you creating services where you have skilled workers to address complex feeding issues? And so there isn't a specific number to target. I think it depends on what the primary piece is, but I think it's important to make sure that's part of the program plan from the very beginning, and then help in working with your budget to make sure that happens.
Thanks, Kate. Linda, do you have anything to add?
Yeah, I just wanted to maybe re-mention some of the resources that we indicated in the presentations, particularly the ones on the Global Nutrition Cluster Working Group, Disability Working Group. There is a tip sheet, particularly for the HRPs, and and I think it's useful to use these tools to help with the planning and the budgeting, right? So if we plan ahead, including in the assessment, including in the risk analysis, including in what is our inclusive response, and what is our monitoring, etc., and all of these would help us to include that budget and not necessarily have it like a distinct, right? It needs to be integrated within, and therefore I think these tools would be useful for that. Over. Thanks.
Now, I think maybe to add to that it's an important point that Linda makes, that actually this doesn't need a whole separate independent program. It's about integrating it. So it'll be mainly the same staff doing it, using the same approaches, just delivered in a slightly different way. And I think it's also important to remember that just being caring and kind when you're assessing patients is completely free, and actually makes the consultation a lot more satisfying, not only for the carers and the child involved, but also for the healthcare worker. So, and that goes across not just disability nutrition, but that goes across all areas of healthcare. So I think lots of the skills that are actually key to making this a success. So looking at empathetic, good communication, actually communicating rather than just talking at people, listening to people and trying to identify what are their concerns, what are their questions. I think that's completely free, very doable, and that would be transformative not only to this aspect of care and programming, but actually cross-cuts across all aspects of what we're trying to do in the wider healthcare community. So just having it as part of training would actually really help with many other things as well, and is cost minimal.
Great, thank you. And actually that links to a couple more, which I'll mention just now regarding trainings. Perhaps we can put some links in the chat to direct participants to some of those trainings that are available. And then the last question before I hand over to Nikki, there's a couple questions about kind of not showing weight gain and the nutritional status of infants. And are there tables or references or values that we can use for weight gain or motor skills, satisfactory development that is available for participants or for program?
Yeah, I think that there are lots of disability specific weight charts, like there are weight charts for Downs and other types of disability, but then that gets very complex and very bogged down. I think the simple thing to remember is that firstly, it's very disability dependent. So, a child who has a visual impairment is going to have very different, should have a pretty normal growth compared to a child with severe hydrocephalus or cleft lip or cleft palate. So number one, take into account what the disability is. And number two, as a rule, remember that they won't grow as well as all other children. So the game is not just weight gain. The game is about that quality of care, the quality of life, making sure that they feel that they're moving forward, that they're developing at a rate that's appropriate for them, they're moving forward. And I think not to discard them, not to get disappointed. And I think especially for program managers, not to discount outcomes and not to see things as a failure if all children are not reaching nutritional cure or the weight-based statuses, because I think that's not what it's about. And certainly my experience that there are cases where infants and children with disabilities are not included in programs because it makes the figures look bad, because they relapse more, they get readmitted, their weight gains are poorer. So we need to get beyond that and admit them because they need care. And if we can to avoid that problem of analysis, we can analyze them separately and look at children without disabilities for the main analysis. But really the key message is focus on quality of care, quality of life as what really matters for disability. Weight gain is nice, but it's not the most important thing.
Great. Thank you so much. Thanks, Kate and Marco and Linda. I'll hand over now to Nikki with the MAMI Global Network.
Thanks, Brooke. Thanks, everyone. As she said, Nikki Dent from the MAMI Global Network. I had the privilege of closing this very stimulating and practical webinar. So I just have 3 quick points. So the first one is, before you sign out, a big plea that you'll just complete a very short assessment on how you found the webinar. It helps us to strengthen the future webinars because this is part of a series. So really would ask you just to hang on at the end. We'll do it just after I finish speaking, and it will be available in different languages, because the more feedback, the better we can evaluate the needs, and also your voice really does count. Second point is that all the materials, the presentations and the recording in different languages will be shared through the Global Nutrition Network, starts through the GNC. We are aware there were many questions sent in before and also during this webinar, so we will try to look at those and collate some responses to those as well. This webinar is just part of a step of many things that people are trying to do with disability. If there are specific wants or questions, there is a help desk, and there's also technical support through the Global Nutrition Cluster. You can see the QR code on the screen. So if you need remote or in-country support, hire a consultant. Technical, this can be for infant feeding, it can be for acute malnutrition, under 6 months, wanting peer support. you can look at this. There's also Ianette have a question where you can actually pose questions in the box 4 there. So please do use these, because the more we ask questions about feeding difficulties and disability, the more we will raise the awareness with donors, with policymakers, with researchers. Next slide, please. Back, yes. Okay, so this shows you the website. So it shows you how you just click. It really is very quick and easy, about 5 minutes, and it's available in different languages. So we do encourage you to use this for questions or requests for technical support. And before we go to the webinar evaluation, the last point I have is just a huge thank you to everybody. Alessandra Lilamo, who's really led us through this and coordinated us, because it's been fantastic to have the different groups come together, the IFE core group, the MAMI Global Network, the Disability Working Group, UNICEF and the Global Nutrition Cluster. It's been, and many volunteers have been behind the scenes. So huge thanks to all of those. A big thanks to our speakers and panelists, Linda, Maureen, Marco, and Kate. You've been very great at answering those, and we will continue to try to address the various questions. And thank you to our translators who have been keeping up in Arabic and Spanish and French. We really want to make this accessible to as many people as possible. We will try to share the resources again and the various training resources as well. And thank you lastly to all those who have participated. We know many of you are on the front line, so doing valuable jobs and very challenging professionally and personally. So we hope this has been valuable. And as we said, it's part of many things that are going on. So I will pass you now to the evaluation. Please just do this for us. Your voice does count. And thank you, Asante Sana, Shukran, gracias. What else have I said? It's been really good. Can you open the webinar evaluation, please? It'll come when you close the webinar. Thank you.